So now we will deal about part 3, leprosy epidemiology and its control. In this part we will deal about the National Leprosy Eradication Program. The emblem symbolizes the beauty and purity of in lotus, that is leprosy can be cured and a leprosy patient can be useful member of the society in the form of partially affected thumb, normal four fingers representing the shape of a house, the symbol of hope and optimism in a rising sun. The emblem capture the spirit of hope, positive action in the eradication of leprosy. Now there are two terms, elimination versus eradication. In case of leprosy, it is oftenly confused elimination with eradication. According to WHO, elimination implies a prevalence rate of less than 1 case per 10,000, whereas eradication means to reach zero level, a condition where no infection remains and there is no possibility of further transmission. Now there are milestones of leprosy eradication in India. In 1898, British India, their Lepers Act was launched. In 1925, Indian Council of British Empire Leprosy Relief Association was established, that is BELRA. That is after independence in 1948, this association was renamed as Hind Kusht Nirvan Sangh. In 1955, National Leprosy Control Program was started by Government of India, wherein Dapsone domiciliary treatment was given through vertical units and survey, education and treatment activities were implemented. Following the recommendation of WHO Study Group Geneva in October 1981 and Dr. M.S. Swaminathan Committee in 1981, the National Leprosy Eradication Program was launched in 1983 by Government of India with the objective to arrest the disease activity in all the known cases of leprosy. However, coverage remained limited due to a range of organizational issues and fear of disease and the associated stigma. In order to strengthen the process of elimination in the country, the first World Bank support project was launched in 1993. In 1998, Modified Leprosy Eradication Program, Modified Leprosy Elimination Campaign was initiated. In 2010 to 2004, second phase of World Bank project of National Leprosy Eradication Program started for a period of 3 years, that is 2001 to 2004. In 2004, leprosy is integrated with general health services. In 2005, as the National Rural Health Mission was launched, the program was subsumed under the aegis of NRHM and being implemented as a centrally sponsored scheme as per the defined rules. The disease has come down to a level of elimination, that means less than 1 case per 10,000 population at the national level by December 2005. In 2006, Disability Prevention and Medical Rehabilitation was introduced as a component of National Leprosy Eradication Program. DPMR guidelines for primary, secondary and tertiary level was introduced, and in 2011 these guidelines are revised. In 2012, Special Action Plan for 209 high endemic district in 16 states and UTs. In 2016, revised operational guideline for LCDC, that is leprosy case detection campaign was introduced. In 2017, Sparsh Leprosy Awareness Campaign was introduced. Now, authentic epidemiological situation in India is available up to 2018. There are 208,619 new leprosy cases registered globally in 2018 from 159 countries, that is 6 WHO regions. It is based on 1,84,212 cases at the end of 2018. The prevalence rate correspond to 0.2 per 10,000 population. Now, epidemiological situation in India, as per 2018 data, Chhattisgarh state and UT Dadar and Nagar Haveli yet to achieve elimination, that is prevalence rate 2 to 5 per 10,000 population. Bihar, Jharkhand, Odisha and Lakshadweep have reported prevalence rate more than 1 per 10,000 population, and India detected 1,20,334 new leprosy cases during the year 2017 and 18, with a multibacillary proportion of 50.9% and female proportion of 38.8%. In 2018, pediatric cases 9,227 child and 4,552 grade 2 disability cases were detected. Now, what are the different components of National Leprosy Eradication Program? That is, first, decentralized integrated leprosy services through general health care system. Second, capacity building in all general health services functionaries. Third, intensified information education and communication program, prevention of disability and medical rehabilitation, and intensify monitoring and supervision. Now, what are different major initiatives were taken? First, early detection and complete treatment of new leprosy cases through routine and special efforts. Second, strengthening of disability prevention and medical rehabilitation services. Third, involvement of ASHAs in the detection and complete treatment of leprosy cases. Next, information, education and communication activities in the community to improve self-reporting to primary health center and reduction of stigma. Next, intensive monitoring and supervision at PSC and CSC level, carrying out household contact survey in detection of multibacillary and childhood cases. Now, decentralization and institutional development. Services are available from all PSC and other health centers where a medical officer is available. District nucleus, that is medical officer and paramedical workers, has been formed to supervise and monitor the program, that is known as district leprosy cell. Already existing state leprosy societies are merged into state health society under the NRHM. Now, involvement of ASHAs, early detection of suspected cases of leprosy, follow up all the cases for completion of treatment in scheduled time and also look for symptoms of reaction, advise and motivate self-care practices by disabled cases, and spreading awareness. Now, what are different incentives which are given to ASHAs? On confirmation of diagnosis, rupees 250 is given. On completion of full course of treatment in time, in case of possibacillary, additional 400 is also given, and in case of multibacillary, additional rupees 600 is given. At an early case detection before onset of any visible deformity, rupees 250 is given. A new case with visible deformity in head and hand, rupees 200 is given. Now, disability prevention and medical rehabilitation. Main activities are implementation of these activity and reporting its outcome, that is treatment of leprosy reaction, ulcer, physiotherapy, reconstructive surgeries, and providing MDR footwears. Integrating DPMR services, that is different department under different ministries, and convergence of National Leprosy Eradication Program into NRHM, and development of different referral system. What are different objective of DPMR? First, adequately manage the occurrence of disability. Second, assistance to persons with disability and prevent worsening of existing disabilities. Third, correction of deformity by reconstructive surgeries. Now, DPMR plan to be carried out in 3-tier system, that is referral system. Primary level care is given at PSC, CSC, sub-divisional hospital, urban leprosy centers and dispensaries. Secondary level care is given all district hospital and district nucleus unit. Tertiary care is given at Central Government Institute, ICMR Institute, Jalma, Agra. ILEP Support Hospital. ILEP is a federation of autonomous anti-leprosy non-governmental international organizations which are supporting medical, scientific, social and humanitarian activities for relief and rehabilitation of persons affected by leprosy. All PMR Institute and Department of Medical Colleges are at tertiary level care. Now different incentives. An incentive of rupees 8,000 will be paid to all persons affected by leprosy undergoing major reconstructive surgeries. Rupees 5,000 to all government institute for providing RCS in their own institution. An additional amount of 5,000 will be paid to all government hospital and institution for providing RCS in camps against outside the institution. Now 12th 5-year plan in 2013-2017, what was the different objectives? To eliminate leprosy, that is less than 1 case per 10,000 population in all districts of country, to strengthen disability prevention and medical rehabilitation of person affected by leprosy, to reduce the level of stigma associated with leprosy. Now there are 3-pronged strategy of National Leprosy Eradication Program. These are introduced from 2016 to 17. There are different components. The quantum of innovation have been introduced under National Leprosy Eradication Program from 2016 to 17 onwards in phase-wise manner. Majority 3-pronged strategy for early case detection, that is LCDC, that is Leprosy Case Detection Campaign, FLC, that is Focused Leprosy Campaign, and a special plan for case detection in hard to reach areas. Other major innovative were Sparsh Leprosy Awareness Campaign, that is SLAC, Grade 2 Disability Case Investigation and ASHA based surveillance for leprosy suspects for enhanced early case reporting. In Leprosy Case Detection Campaign, that is aimed at early detection and timely treatment to reduce disability in highly endemic districts. FLC is carried out by ASHA and multi-purpose health workers by house-to-house survey, that is covering 300 households, wherein 1 case for grade 2 disability due to leprosy was detected, and that is pointed as hotspot. Now special activities, Sparsh Leprosy Awareness Campaign, that is SLAC. It was felt that the major cause of hidden cases is lower voluntary reporting in the community due to a lack of awareness as well as continuing fear, stigma and discrimination against leprosy. SLAC was launched on 30th January 2017 through the Gram Sabhas and carried out with the help of Panchayat and Village Health and Sanitation Committee. What were different measures included? That are contact tracing, examination, treatment and chemoprophylaxis will bring down number in the important vulnerable group of household contacts. The special emphasis on women, children and those with disabilities is expected to flush out more hidden cases. Now there are set scheme, that is survey, education and treatment. NGOs are involved in disability prevention and ulcer care. IEC referral of suspect cases, referral for reconstruction surgeries, research and rehabilitation, and NGO support. It's mainly required for follow-up of the under treatment cases in urban localities and difficult to reach areas. Now what are different IEC, BCC, Leprosy Free India objectives are to develop effective communication to target audience by IPC, interpersonal communication, to complement and support the detection and treatment services, to strive to remove stigma and prevent discrimination, and active participation of community and client. Now what are different standard messages? Leprosy is a disease, not the curse of God. Leprosy is completely curable if treated in time. Full course of treatment is available free of cost in all government hospital and health centers. Disability, deformity due to leprosy are not inevitable and can be corrected by reconstructive surgery, self-care and simple exercises. Leprosy does not spread by touch, nor is hereditary. Leprosy affected person on treatment can live a normal life along with the family. Now define tools and methods depending upon the target audience: mass media, outdoor media, rural media and advocacy. Now, what are different target audience? Selected communities with deep-rooted stigma, leprosy affected persons, general healthcare staff, NGOs and community-based organization, and disabled people organizations. Now, there are Global Leprosy Strategy 2016 to 2020, that is accelerating towards a leprosy-free world, was officially launched on 20th April 2016. The overall goal is to further reduce the burden of leprosy while providing more comprehensive and timely care following the principle of equity and social justice. Now, vision is zero disease, zero transmission of leprosy infection, zero disability due to leprosy, and zero stigma and discrimination. Now, what are different targets? Disability among new pediatric patients should be zero. The grade 2 disability rate less than 1 case per million population. Number of countries with legislation allowing discrimination on basis of leprosy should be zero. Now, Global Leprosy Strategy, that is accelerating towards a leprosy-free world, aims to strengthen the effort to control leprosy and avert disability, especially among children still affected by disease in endemic countries. It emphasizes the need to sustain expertise and increase the number of skilled leprosy staff, improve the participation of affected person in leprosy services, and reduce visible deformity as well as stigmatization associated with disease. Also calls for renewed political commitment and enhanced coordination among partners. Now, what are different core pillars? There are 3 pillars: strengthening government ownership, coordination and partnership, stop leprosy and its complication, stop discrimination and promote inclusion. Now, indicators are tools that are used to measure progress and achievements under a program. The following indicators are used in the National Leprosy Eradication Program, that is essential indicator. Essential indicators include annual new case detection rate per 10,000 per lakh population, rate of new case with grade 2 disabilities per lakh population per year, treatment completion rate as proxy to cure rate, and prevalence rate. Some additional epidemiological indicators are proportion of grade 2 disability among new cases, proportion of females among new cases, proportion of multibacillary cases among new cases, proportion of child, that is 0 to 14 years among new cases, child rate per lakh population, and scheduled caste new case detection rate, scheduled tribe new case detection rate. Now, quality of service indicator, that is patient month blister calendar pack stock, absolute number of patient made RFT, number of relapse reported, proportion of cases who develop new or additional disability after starting MDT, proportion of treatment defaulters, proportion of new case correctly diagnosed. Now, anti-leprosy activities in India, there are different associations: Leprosy Mission, Hind Kush Nirvan Sangh, Gandhiji Memorial Leprosy Foundation, Sevagram, in German Leprosy Relief Association, Demin Foundation, the Nani Shave, the Child Fund, Jalma, National Leprosy Organization. Now, World Leprosy Day is observed on the last Sunday of January every year. Now, thank you. Leprosy work is not merely medical relief, it is transforming frustration of life into joy, of dedication and personal ambition into selfless service. Thank you.